let's start about so, good afternoon. And I just give intention that this is a fact. I like to give it early in the morning where you are alert and ready for me. I don't think you will be listening to anything I'm going to say. That's my own feeling. So unfortunately, I was given this lecture at 4. But anyways, let's make the best out of it. Eid Mubarak for all. And hope you had a good, relaxing vacation. Don't tell me you were studying. Don't. I will not get this. Were you studying?
No, we were.
Bravo, alaykum. That's what I need from you. Okay, so we're continuing on the concept of thyroid and drugs for thyroid. Yeah. So drugs used for thyroid disorders. This was supposed to be delivered by Dr. Dilip, but Dr. Dilip is out of town, so I took over. And for today, we will be. ليش ما بيشتغل؟ Okay, back. Okay, so we're going to review the steps in hormone thyroid hormone biosynthesis. Why is that? Just to be able to highlight where are the sites of drug action, and specifically the when we want to treat hyperthyroidism, we want to know where's the site of activity of these drugs. So we need to just refresh our memory regarding hormone biosynthesis, release, and regulation. And then discuss the mechanism of action of these drugs, whether we're talking in the treatment of hypothyroidism or hyperthyroidism, adverse effects, and pharmacokinetic parameters. Okay? And then we can compare, we would say which one we give as first-line therapy. That's only in the hyperthyroidism. In hypothyroidism, it's only giving levothyroxine or leothyroxine. Okay? So we have drugs for the treatment of hyperthyroidism, and we're going to discuss which are the advantage and disadvantage of these drugs, and then we're going to talk about radio-labeled iodine and surgery. Okay. So we all know that the thyroid is mainly involved in the metabolism, in the growth, and the development and metabolism. And there are basically 3 hormones. Today we're mainly concerned with 2, T3 and T4. But also, as you all know, thyroid gland releases a hormone called calcitonin, and it's mainly involved in calcium metabolism. When we discuss osteoporosis, or if you have discussed it already, calcitonin fits perfectly there. Okay, so the pathways involved in the thyroid function. We start, remember when we discussed last time growth hormone and prolactin, we start with our hypothalamus. And as you all know that the hypothalamus receives a lot of signals. These signals vary, and accordingly, the release of what we call release or inhibition of what we call TRH, or thyrotropin releasing hormone, or TSH releasing hormone. So we can call them both. They're all both correct. In turn, this TRH will release or will stimulate the anterior part of the pituitary gland, and that is thyroid stimulating hormone or thyrotropin stimulating hormone, TSH. Okay? This TSH, please remember that it stimulates the thyroid gland, right? So the receptor that the TSH binds to, do you know what type of receptor is that? Huh, guys? What type of receptors the TSH binds to on the thyroid gland? It's a G protein coupling receptor. G protein. So let's distinguish between the T3, T4 type of receptors and the TSH type of receptor. Okay, so it is expressed on the membrane of the thyroid gland. That's the TSH. Okay. And so the TSH, what does it do? Do you know what does the TSH do to the thyroid gland? It just basically triggers the T3, T4, right? And also it has a role in the cell division, in the growth. So we have release of T4, T3, that's perfect. But please also remember that there are minute amounts of T3, T4 that are released into the circulation in the free form. Most of these hormones are protein bound. Okay? Yani if I can say like a number, every 5 molecules of free T4 to 10,000 molecules of bound T4. Or every 10 molecules of T3 to 1,000 molecules of bound T3. So mainly they are protein bound. They're very closely bound. So once these T4, T3, the free form is released, they are active to bind to the receptor, which is intracellular receptors, nuclear receptors. And then they would trigger synthesis of proteins that are involved with metabolism and growth, etc. Okay? And so when we say metabolism, and we also say regulation of temperature. So recall that whoever is in a state of hypothyroidism, they tolerate, they cannot tolerate the cold weather. They are very sensitive to cold weather, like us now in this room. We're all hypothyroidism. Okay? Okay. So again, just as a refreshment to the role of TSH, first of all, it stimulates the uptake of iodide into the thyroid gland, synthesis and release of thyroid hormone, and growth promoting effect. Why I'm saying growth promoting effect? Because TSH is also involved in this when we see an enlarged thyroid gland. This is because we have too much TSH. Again, I'm just refreshing your memory into what stimulates and what inhibits the thyroid release. Remember, we talked about somatostatin when we discussed growth hormone. Somatostatin also can inhibit the TSH. Okay, so here we go. We have the cold can stimulate the hypothalamus to release TRH. The severe stress can inhibit release of thyroid releasing hormones. So people who are not acute, not okay, but the chronic part, the chronic state of stress can inhibit the TRH as a result of it. Huh? Medical students. So we put next to chronic stress a medical student image, then we understand what really we are talking about. Okay? Okay. So here there is something very interesting that we need to remind ourselves of. Small amounts of iodide. Please, you know that I'm saying iodide, not iodine. Do you know the difference? Yes. Okay. What's the difference between iodide and iodine? Which one goes into the thyroid gland? Iodide or iodine? Here. Huh? Iodine. Iodine, which is I2? No, iodine. Or iodide, which is ionic, yani I minus. I minus. Okay, so the iodide, the ionic form of the iodine is the one that is more prone to get into the follicles or into the thyroid gland. Okay, so the last point is very important because we're saying that small amounts will trigger the stimulation of T4 and T3, right? Small amount of iodine are necessary for hormone production, but large amounts, we call them pharmacological amounts of iodide can do what? Can inhibit T3 and T4 production and release. And why I'm saying that? Because in certain cases, we would treat hyperthyroidism by giving glucose rich iodide, potassium iodide, okay? Because we're giving high amounts. But it's not popular, it's popular in certain cases, okay? So you got the difference. When we give small amounts, it's necessary to produce the T4, T3. But when we give large amounts, this will lead to the inhibition of the release of hormones. Okay. Now let's take the steps. Anyone is, I think you're familiar with the steps?
Yes.
Okay. Can someone help me with each and every step? Go ahead.
So first, there's going to be uptake of the iodide to the sodium iodide.
Okay.
And then the iodide has to.
So here we go. So you said iodide uptake, we call it trapping, which is actively taking. What do we mean by actively taking? Against concentration proteins, right? Okay, so this is the source. The thyroid gland is a source. It's very favorable to uptake of iodide. Okay, then what?
Then it has to be converted to iodine.
So back to the I2, which is oxidation, right? Okay. And what's the enzyme responsible? Thyroid peroxidase.
And then thyroid peroxidase again is going to couple the organification, so iodine to the tyrosine.
Okay, so tyrosine came from where?
The thyroglobulin.
Thyroglobulin. Okay, so the thyroglobulin is a scaffolding protein. Scaffolding protein. Okay, I'm gonna be the framework, the godfather of this whole process. And I am a protein that I have like 100 residues of tyrosine. And these tyrosines, which is the structure right here, it's a phenol ring, and we have R. And then from there, these tyrosine residues are gonna take up the iodide, right? From the I2, correct? So this is called iodination. So iodination can be
One iodine.
monoiodotyrosine or diiodotyrosine. Now what? What's the next step? And this is through what enzyme? Okay, same enzyme. Okay, same enzyme. So this enzyme is important. We are interested in this enzyme, right? I'm interested in this enzyme. Now what?
Coupling of the mono and
Okay, so now we're coupling two iodinated tyrosine, either mono, either di or di-mono. So triiodo or tetraiodo. And from here we get what we call T4 or T3. Now, the next step is, where's the next step?
release.
The release. The release from what? From where? Release of T4, T3. Remember, we said we have scaffolding protein, which is thyroglobulin, which is responsible for the storage of these hormones. Now we need to release it. So we release the T4 and T3 from the scaffolding protein. Okay, this is how we get a free T4 into the circulation through proteases. Okay, so we have a whole picture here, right? Is everyone clear? You want me to repeat it? Are you sure? Okay. So why we're saying all of this? Because these are steps, sites of action for our drugs that we want to use. Okay? This is site of action. Where could be a good site of action for patients who are producing a lot of T4, T3? Thyroid peroxidase. What? TSH receptors. Okay. What else? Huh? The uptake. Yes, you mean the iodide trapping. Yes. Yes, so it could be this site, it could be the enzyme, it could be the protease, Yani, I will not release you. If I don't release you, you can't go into the circulation. If the thyroglobulin holds these T4 and T3 into their structure, there will be no release into the circulation. So if I have something that will inhibit the protease, then I will not have a released T4, T3. So again, the enzyme, the trapping method, which is we can inhibit the uptake, right? Or the protease. Now, what else? Now, once the T4 is released, we have in the periphery something is going on.
Inactivation.
Inactivation?
No, activation.
Activation of what? Okay, so we have deiodination. Deiodination that takes place mainly with kidneys, with liver. So this deiodination can also, is it a site or not?
Yes.
This could be a site too for us to, why? Why I'm saying I don't want T4 to turn into T3.
Yeah, T3 is active and T4 is not.
So T4 is to to a lesser extent, the activity of T4 is less than T3. And so when I inhibit the conversion, I am doing something as well. Okay. Okay. This is not clear. Is it clear on the screen? It's a bit tiny. It's not. It's basically the clinical part. So what do we have here? What do we have here?
The things that happen during age.
So this is the clinical symptoms of hypothyroidism and hyperthyroidism, which you should know by now. But just as a refreshment, we're talking about, when we speak about hypothyroidism, someone who is pretty tired, pretty weak, from the least activity, they lost their energy. They have poor concentration and memory. Usually the skin is something really dry, coarse skin, and hair. They lose their hair sometimes. Cold intolerance. It's always that cold intolerance that can be significant. Cold body extremities. And they can have poor appetite, but then, as we said, because thyroid is involved with metabolism, they can gain weight very easily. Okay? Swelling, puffiness of hands, feet, decrease in heart rate. Yani we're talking bradycardia rather than tachycardia. Okay? They might, of course, both hyper and hypothyroidism can affect fertility in female. And in general, the complications of thyroid gland, whether hyper or hypo, they're 5 times more in females than in males. Okay? Yes. Okay. So hyperthyroidism, we see hyperactivity followed by fatigue and weakness. This anxiety thing, they become anxious. Patients become anxious. Again, we have heat intolerance. Yani whenever anything, they're always taking off their clothes. They can't tolerate heat. The eye, they appear bulgy in certain cases. Weight loss, although they have the appetite. هذا كلنا بنصير hyperthyroid. And we can eat, but still we're not gaining weight. Okay? Increase in heart rate. And this is basically why we like to use adjuvant therapy, مثل beta blockers, to take care of that tachycardia. Okay? And also it can affect the periods. It can become scanty and frequent periods in women. These are the drugs that we will be discussing for today. In hypothyroidism, which is straightforward, either we're giving T4 or T3. Okay? So levothyroxine, another name for T4, or liothyronine. In hyperthyroidism, we're going to be giving something called thioamides, a group of drugs, 3 drugs mainly. They're called thioamides. Example, propylthiouracil, but that's not all. Now, beta blockers is considered as an adjuvant therapy. We know why, because hyperthyroidism leads to this tachycardia. These are the, in terms of medication and popular medications, these are the most popular. Now, iodide, which is the Lugol solution, it's not first-line therapy. We rarely use it on its own. Mainly, we try to use it pre-surgery. Prior to surgery, we like to give Lugol solution, okay? Now, so we have in this case, we want to basically shrink the gland. So we have two options, either through surgery, and by the way, this is not our first line therapy. This is when the clinic or when the medical or the medications fail, then we go for our surgical approach. And the other one is the iodine 131. Okay, so let's start discussing each one of them. In hypothyroidism, there are three preparations, either T4 on its own, levothyroxine, liothyronine, T3 on its own, or the combo, Liotrex, T4 plus T3. Okay? Well, which one do you think is the most popular? Why? Why is it both of them are cheap? La? I'm saying one is more expensive. Okay, what else? Let's what other side. يعني لما تقولي لي
not technically, but yeah, مثلا we're gonna get
it can cause hypothyroidism.
yeah, palpitation, something.
Why?
Because we have a lot of the half-life.
The half-life of T4 is very high. You know how much is the half-life of T4? 7 days. And still we give it every day. You're going to tell me how. Who said 7 days? How do you know?
I think it's on the slide.
It's chronic. Okay.
That's good. T4 is converted to T3 anyway.
That's a good point. I like it. Because T4 mainly is converted to T3, so I'm basically I got the best of the two worlds. Okay. And also one of you mentioned that because the T3 is more active, so I'm at risk of palpitation, of tachycardia, way more. So the toxicity can be way more than the T4. Okay. So does that mean that I don't use T3 at all? No, I don't use it. No, I'm just, someone said no.
You do use it.
You do use it. When do I use it?
It's T4. I do.
If T4 did not work. Okay. So let's say we have hypothyroidism and I started the medications and I'm giving T4 and I want to monitor. How do I monitor these patients? How do I monitor them? By measuring what?
Yes, sir.
Hit that.
Iod?
With T3 and T4.
Which T4, T3?
Not three, T3.
Free T4, T3. Okay, so we have to measure the free T4, T3 and the TSH. So I expect once I am treating with T4, let's say the most popular, that these numbers are going to get better. What do I mean? And TSH is going to go down back to normal. T3, T4, right? Normal. So T3 can be good whenever we clinically we feel better. Symptoms are getting way better. But maybe the TSH is not going back to normal. Maybe then we might use or add the T3, okay? But not in all cases. So, levothyroxine, first of all, it's a synthetic thyroid replacement therapy. We start with lower doses in elderly. It's given every day on an empty stomach, and we monitor it by monitoring the TSH. What's the advantage? We have a uniform absorption, stable, low dose, and it's very easy to monitor. Now, the question is, your friend looked at the slide and saw half-life 7 days. And do I give it once every 7 days? No. Why? It's the half-life is 7 days.
Yeah.
Actually, in order for us to get optimal serum levels, we try to take, it's around, let's say, 500, 600 micrograms. So we divide them, so the dose is 50 to 100 micrograms. Okay? And so we turn into once daily administration. Lipothyroxine, it's 3 to 4 times more potent, that's why we try to avoid them. And it has a shorter half-life, higher dose, okay? The monitoring is a bit more difficult, and risk of cardiotoxicity is there more than levothyroxine. So, question. This elderly patient, we trying to initiate therapy for him, and he has been having hypothyroidism for some time now. Why is it important to begin with small doses in his case? I'm not sure his or her, but anyways. And I'm saying elderly. Why should I start with low doses for that patient who has been hypothyroid for some time now? Go ahead. No, there's options. Can you help me with the options? It's an MCQ. D.
Your body is in a normal level, and now you start getting so much stimulation, so it can affect your organs.
Okay, and you're correct. Overstimulation of the heart. Okay, clear? Now we're moving to hyperthyroidism. The hyperthyroidism, we need to make sure we're trying to inhibit. There's a lot going on, and I want to inhibit the production of too much T4, T3. So what do I do? What's my goal? And if you look here, there's a small word called, we need to achieve euthyroid state. Why I'm saying euthyroid, which normal state, euthyroid. So in hyperthyroidism, I want to treat, and I have goals for my treatment. But ultimately, if I reach euthyroid, that's my goal. Why I can't say, okay, I want to reach treatment like normal state of the thyroid. Why I'm saying euthyroid?
You can't because it's about
I can't reach normal. Why?
because it's like everything is a very threshold.
Because
Everything is like the higher threshold.
there's a very high chance of rebound. There's very high chance that things will be back. Okay, will be back to its pathological state. Okay, so we call it euthyroid because this could be temporary. Hopefully, we're looking that it will stay for forever, but still there is that chance, sometimes more than 50% chance, that the euthyroid will go back to hyperthyroidism. Okay, so what's my goal of treatment? My goal of treatment is to inhibit the synthesis of the hormone. That's one of my goals. Or either I'm looking at the synthesis or I'm looking at the release. If I can't release, I don't have the hormone in my circulation. So inhibiting the release is a good thing. The third thing, the peripheral conversion from T4 to T3. Remember, we said peripherally there is this conversion, and we know that the T3 is 3 to 4 times more potent than T4. So if I said I am inhibiting deionation or deiodination of T4, that's a good goal. If one of the drugs does that, I'm gonna work with that drug. Okay. The other thing is when I have to remove part or all of the thyroid gland, surgically or non-surgically. What's the non-surgically? Right. Okay, so we're good. The anti-thyroid medications, thioamides could be one of them. Now I'm going to be starting with a drug that's not mentioned here. In the coming slide, I'm going to start with a drug that's not mentioned here. I'll tell you why later. So thioamides is one of the drugs. Radioiodine, which you have told me that it's non-surgical removal of the thyroid gland. Iodide, remember we said we have local solution, we use it in certain cases, that's another option, but not our first option, we use it in certain cases, but that's listed in this slide. Adjuvant therapy. Adjuvant therapy could be beta blockers, and we know why we use beta blockers. Okay, so we want to decrease that sympathetic innervation, and so we give a beta blocker, okay? And sometimes we use it for Graves' disease, and you know what Graves' disease? What is it? Guys at the top, what is Graves' disease? And in the past I used to call it Graves. It's autoimmune, so when I give glucocorticoids, I'm trying to do what? Some kind of immunosuppression. Okay? Okay. So, look, this is what I was telling you about, that one of the treatment options is something called ionic inhibitors. Ionic inhibitors. And we have two drugs, thiocyanate and perchlorate. Guess what? Why I didn't enlist them? They're removed from the market. They're no more in the market. Okay? Why? They can yes. Because of their severe allergies. Okay? Now you're gonna see me talking about agranulocytosis as a side effect, very rare side effects in the other drugs. But this one was the mortality was very high and it had high incidence of agranulocytosis, and as a result it was removed from the market. But look, the site of action is when? In the uptake of iodine into the follicles. Okay? So it inhibits sodium iodine synthase, which is, of course, integral protein of the basolateral membrane, the thyroid gland. And so with that, the first drug who has, it's like history, but we need to know it, that how does it work and why has it been removed from the market. That's it. Now, the second group is the thioamides. We have three drugs. Propylthiouracil, PTU, propylthiouracil, then carbimazole, methimazole. Carbimazole is a prodrug for methimazole. So basically they're the same. The three drugs. Okay? One is a prodrug of the other one is called propylthiouracil. Remember the letter P. We will link it now. Okay? What do? They inhibit the enzyme thyroid peroxidase. How many steps is this enzyme involved in?
Everything.
Yeah, everything. It's involved in what? Can you please enlist them? Oxidation, which is from the iodide to the iodine. What else? And the iodination with the tyrosine and coupling. So when I say I'm inhibiting thyroid peroxidase, I'm doing a lot, right? So that's where the popularity of that group of drug came from. Okay? Now, what about the propylthiouracil? Yani, let's put them two groups, carbimazole, methimazole, and propylthiouracil. Propylthiouracil has the same mechanism of action as carbimazole and methimazole. However, propylthiouracil has something extra. Inhibits the conversion of T4 to T3 in the periphery. So that's an extra step. Okay? Now, if I give these drugs for someone who is hyperthyroid, do I expect the action to be instantaneous?
No.
Why? Okay, it has no effect. Whatever has been stored in the thyroid globulin, whatever has been manufactured and stored, we have nothing to do with it. We have to do with the newly synthesized or newly activated T4 and T3. So we have to wait. How much we have to wait? Almost around a month.
reduce the other side of the time.
Maybe we can use a beta blocker, and actually beta blocker goes a long way with these regimens. There's no, go ahead.
So what is the effect of the unfairly within changes with this consultant?
Yes, but I'm talking, yes. Now, propylthiouracil, I'm going to tell you so many good things about propylthiouracil, and then I'm going to let you down. Okay, so hold on. So propylthiouracil has an extra mechanism of action, and it is from the word P. From the word P, first of all, let's say that they are all given orally, which is very good. Absorption is very high. And we said carbimazole is the drug for methimazole. So here we go, converted to methimazole. Now you can see that PTU, propylthiouracil, is a very short half-life. However, I give it every 8 hours. Then the methimazole, now the methimazole and carbimazole, they're given once daily, which is considered an advantage. And if I give something once daily, over 3 times daily, is considered, okay, fine. But interesting, someone would ask me, how come I'm not giving it every 2 hours? It has a very short half-life. Why? Actually, because of the affinity to the thyroid gland. So the propylthiouracil is absorbed, goes to the circulation where we measure the half-life. So how do we measure the half-life? We see, okay, how much PTU now? And then we see that the PTU is gone. Okay? If it's gone to be eliminated or excreted, that's something that's called the regular half-life. But actually, it goes to the periphery and gets stored in the thyroid gland, which is the cycle of action. That's why it stays longer, and we don't need to give it every 2 hours or every 3 hours. We give it every 8 hours. Okay? Okay, so the other advantage for PTU is what? It's given for pregnant women. It's safe to be given. So remember PTU, propylthiouracil, and pregnancy. This is how we link that they are used for pregnant women, mainly the first trimester. Second to third, you can shift to carbimazole, methimazole. Clear? So why I can't keep the PTU for a longer time? Because of the severe hepatotoxicity it causes. And that's why PTU is not considered our first line therapy. You got me? So because of the toxicity, these drugs, it's not considered as our first line therapy. Our first line therapy is still carbimazole, methimazole. Although we are talking good things about PTU. Now, for the adverse effects, rare agranulocytosis. Okay, what do we mean by agranulocytosis? Okay, and so في عندي bone marrow suppression. And what do I do for these patients? If they say 2 to 3 months of treatment, this incidence might occur, so please be careful. How can I be careful? Okay, so I have to do complete blood count on a regular basis. That's very good. Now, what if it showed in 2 to 3 weeks or 2 to 3 months? What do I do? Action plan. I stop. Then what? Okay, so grants are okay, so this can stimulate the immune blood cells, or I can give blood transfusion, okay, as an alternative. So hepatotoxicity, we said mainly with PTU, hepatotoxicity, and that's why it's not our first line therapy. Teratogenicity with carbimazole, methimazole, and minor الراشز. Remember نحن عم نحكي عن سلفا drugs. سلفا drugs كلهم هذول سلفا drugs. So في rashes, في pruritus, this abnormal taste sensation, arthritis, so all of that are linked to these group of drugs. Okay? So we talked about the pregnancy, when to give it. We talked about the first trimester, and we can return to carbimazole, methimazole in the second and third. And we know why. because of the risk of hepatotoxicity. Clear? Now, where's the main issue? This is color. Our main group of drugs has been covered. Where is our issue? That when I give these drugs, I will give them, first of all, let's say, for 4 weeks to see the effect. But if I stop, actually, I might move on to giving half of the dose for a whole year to make sure that I am still good, and then taper it down in a year's time, and watch the patient. Maybe he will go back to that hyperthyroidism. So this is the issue. It says clearly here, the main problem with anti-thyroid medications lies with the fact that the underlying problem returns once they are discontinued. Therefore, many people are encouraged to seek more permanent treatment, such as radioactive iodine or surgical removal. So this is why we start with the medical treatment, with taking drugs, and for a good year, a year and a half. And then if I find out that we're going back to square zero, then I have to start a different approach. That's why surgical approach is not our first approach. Okay, even the radioactive iodine is mainly not our first approach. Our first approach is giving metimazoles, carbimazoles, propylhydrouracil, and then moving on. Okay, this is a good summary for us to see the site of action of the PTU, metimazole, so on and so on. Okay, this is a good summary for you. So T3 has much greater, that's why this is all regarding the transformation from T4 to T3 via deiodination. And this is where the site of action of PTU gives it the added value. Okay? Now, the second approach is when we remove part or all of the thyroid gland. We have the non-surgical and the surgical. I'm not going to be really dwelling about the surgical, guys. This is not my topic. But the non-surgical removal using the radioactive iodine. And how? Through the release of beta particles, which basically kill these follicles. The main thing, first of all, they're given in a hospital setting, although it's an oral form. Yani it's a tablet or a liquid, and the dose is calculated in a very complicated way. The dose of this radioactive iodine, guys, is basically they have to know the size of the thyroid gland, the weight of the thyroid gland. This is when they do the imaging. They calculate, they have these equations on how to calculate the weight of the thyroid gland, the weight of the patient, the age of the patient, and their levels, so on and so forth, in order for them to come out with an accurate amount of the dose of the radioactive iodine. Okay, it's given in hospital setting. It's a one dose thing, one shot. But the issue with what? Is once I go back home, I have to make sure not to keep space with my family members or friends, a minimum of 1 liter. Okay, why? Because first of all, in half-life is 8 days. Usually we are emitting radioactive material even through our secretions, through our urine, saliva, so on and so forth. So keep distance. Don't isolate yourself, but keep that distance. What's the advantage of radiotherapy? It's selective for the thyroid gland, so no tissue other than the thyroid is exposed to sufficient ionizing radiation. Usually the risk of, experiencing the counter side of the case, which is hypothyroidism, is much less in terms of incidence in comparison to the surgical approach. So and what else? When you do surgery, you might hit a nerve, you might hit a neighboring gland, parathyroid, for example. This is not applicable when we give radioactive iodine. Okay? There's no discomfort which is associated with surgery, no hospitalization except for the day when you go and you take the iodine. the cost is much lower, of course, than the surgical one. A disadvantage is what? Is later on they can experience delayed hypothyroidism. Delayed hypothyroidism. With the surgery right away, if there's a mistake, it shows. But with the radioactive iodine, there's a delayed hypothyroidism. Now I'm moving to something called iodide, واللي هي Lugol's solution. And Lugol's solution, as I said, it's not given as first-line therapy, used to in the past, but mainly we are interested in giving it prior to surgery and in fatal thyrotoxic crisis. Okay, so two scenarios for giving Lugol's solution. Lugol's solution is a high concentration of iodine. Remember when we said we give a small amount of iodine or the physiological amounts that we get through diet, so on and so forth. These are good to stimulate the production and synthesis of T4 and T3. However, if I give pharmacological concentrations, such as the one in Lugol's solution, this can lead to what? One of the things, it can lead to the inhibition of conversion of T4 to T3. Okay, this is one of the mechanism of action of iodine. And as we said here, we have something called Wolff-Chaikoff's effect. So Wolff-Chaikoff's effect, and the two scientists who came up with this explanation, who were able to explain why giving too much iodine can lead to treatment of thyrotoxicosis and release. And this is because we found out that giving iodine can block the release of T4 and T3 from the gland, and also it can block the conversion of T4 into T3. Okay? So we are done with the and I had to just before I move on with the surgery. Before we do surgery, we don't only give iodide. We give iodide and we give methimazole and carbimazole. We give it for a good 3 weeks, 3 to 4 weeks. We give sometimes a bit of anxiolytic. We can give beta blockers just to make sure that during surgery, we will not get that huge release of thyroid hormones. Okay, so that's a different regimen. But one of it is giving iodide for the last 10 days prior to surgery, they will give Lugol's solution and they will give it in high doses. Okay. Adjuvant therapy. Adjuvant, you give it with our main treatment. Example, beta blockers. Thyroid. Which is better, propranolol, giving propranolol or atenolol as an adjuvant? Why? Okay, so propranolol, first of all, propranolol, it has an added value other than it affects the control of tachycardia and it controls the cardiovascular effects of hyperthyroidism, but also it inhibits the conversion of T4 to T3. But what else? Propranolol. Why propranolol? First of all, we said one of the symptoms of hyperthyroidism is anxiety. Okay? And so, because of the characteristic that propranolol passes the blood-brain barrier, it also can control the anxious state of patients with hyperthyroidism. Okay? Now, okay, I can give atenolol, I can give propranolol, beautiful. But what if I'm asthmatic? I cannot give, definitely. And what do I do? So alternatively, if that patient has asthma, which beta blocker will specifically propranolol because it's beta non-selective, then I have to give alternatively diltiazem, which is a calcium channel blocker that will control the palpitation and the tachycardia. Okay, this is a nice summary to look at, which means the steps of the thyroid hormone synthesis and the effects of anti-thyroid agents. If we look here, مثلا, active accumulation of iodine into glands, this is where we target the iodine 131. Oxidation of iodine to iodine biperoxidase inhibited by thioamides. Ionization of tyrosine residues inhibited by thioamides. Coupling inhibited by thioamides. Proteolytic release is another characteristic of iodides. So iodides, if they are in large amounts, they will inhibit the release of T4 and T3 from the thyroglobulin into the circulation. Please remember, iodides has an extra role, which is inhibiting the release of free T4, T3 into circulation from the thyroglobulin. Just inhibits it, so keeps it in the large protein with thyroglobulin. Conversion of T4 to T3 is inhibited by propranolol and propylthiouracil. And this is a very good summary for you when you go back for study. يعطيكم العافية.